Thank you. I appreciate the opportunity. And also, I'm the current president of the American Society of Geriatric Otolaryngology as well, so I have a passion for geriatrics dating back to my residency. So today we're going to talk about the key otologic considerations in the geriatric population, both hearing and I'll touch on a little bit of vestibular. Dr. Bojrov did a great job with that, but I'm just going to kind of highlight a couple of things that we may not be aware of with regards to that population. So we'll start off, we'll try to keep it fun, because geriatrics can actually, for a lot of people who aren't passionate about it like me, be a little bit boring. So we're going to define geriatrics, talk about a shifting paradigm, and then talk about aging in otology. So defining geriatrics, this is interactive. If you have your cell phones, please take them out and text to the number 22333 Selena Briggs, that's SELENA BRIGGS 107, or click the QR code. And I believe my is activated, but I'm gonna, yep, got it on my phone too.
Check.
Just give you a second to get on. So just 2 quick questions we'll go through. Everybody there? Good. So starting off with defining geriatrics. How do you define geriatrics or geriatric? Would you say it's over 50, 60, 70, 80, or it depends? It should show. The answer's coming in. Should be activated. Okay, that's interesting. So I can see it coming up on my, yeah, I'll see if it pops up on my next screen.
Well, we can get out of the presentation and see if we're starting it now.
Okay, that might.
Is this a screenshot or?
No, this is yeah, go back to presentation. Let's see if I go to the next slide if it'll show up. Yeah. I can go to the website and kind of activate it that way. Just gonna, give me 1 second. Sorry about this glitch. I could read it off for you. That'll probably be the easiest way. Yeah, just to save time. So, it's okay. Yeah, it didn't come up. That's okay. It's here. I can see it on my phone.
It's just not
Yeah, I don't know why it's not syncing. It might be the. So nobody voted for 50. 36% of you voted for over 60. 36% voted for over 70. 4% over 80, and 24% it depends. All right. Good thing I had this on my phone as a backup. Let's see. Okay. Now for the next question, and I'll read it off for you. If you said it depends, what does it depend on? One or two words. Functional status. Physical ability, functional status. Aging, multiple, continuum, multiple factors, the continuum of aging, frailty, abilities. Great, I agree, thanks. And apologies for that glitch. So again, this is fun, so please don't be offended by anything I project up here. So if you said over 50, the American Society of Retired Persons rate geriatric as being over 50. And now I can say I'm a Saturday Night Live fan, SNL, and one of my favorite characters was Sally O'Malley. And so as I have 40 in the rearview mirror and I'm rearing up towards 50 myself, I can say I can kick and stretch and kick because I'm almost 50. Yeah. For people 60, our age-related hearing loss measures for the American Academy of Otolaryngology goes based upon the age of 60. 65, interestingly, I found out in looking at this research, the FAA has an upper limit for commercial pilots of 60 years of age. So over 60, you actually cannot be a commercial pilot any longer. The World Health Organization and the United Nations, as well as Medicare, define it at 65, and then Social Security is at 67. So most bodies look at that range of 60 to 65, as most of you did, for beginning geriatrics. Interestingly, if you look at the OB literature, it's actually 35 is when they consider you geriatric. If you look at implications, though, of aging, there are a number of implications that are important to be aware of, particularly in terms of physiology, the pharmacokinetics of patients, and drug metabolism. So as we age, our hepatic clearance decreases significantly, as well as does our renal clearance. Therefore, the bioavailability of certain drugs increases in patients, in about 2 out of 3 patients. So it's important to be aware of those changes with the geriatric population. But from an otology perspective, 1 in 3 individuals by the age of 65 will have some degree of hearing loss. 1 in 2 individuals by the age of 75 will have some degree of hearing loss. And we look at age-related balance changes or presbystasis. 20% of individuals by 65 will have some sort of balance disturbance, at least over a course of 12 months. And by the age of 80, 80% of individuals will be affected. But there's more to it, as some of you alluded to, than just your age. So just highlighting a couple of individuals. Charles Euster is a 91-year-old male who was a bodybuilder and worked out regularly with his physical trainer. The individual below, it's challenging to pronounce his last name, but Mr. W.B., we'll put it that way, 71-year-old man who runs a 10K in 44 minutes, which is faster than I could ever aspire to do, and I'm a runner myself. And then this is my patient. She's a 90-year-old female that I performed a cochlear implant on. She was a pillar in her community, and she wanted to be able to continue to communicate with her family and those individuals that she mentored. She did great with her cochlear implant. So really, as we were talking about, geriatric, we don't just look at age currently. Now we're looking at health status, physical abilities, support of that individual, and really that person's personal preference. So we should take an individualized approach at caring for the patients within the quote-unquote geriatric population. So there is a shifting paradigm from looking at just the absolute chronologic age of an individual to the functional capacity of that person or overall health of the individual. And one of those paradigm shifts is looking at the individual with regards to frailty. So if you look at frailty in head and neck cancer, actually patients with advanced frailty scores have higher rates of morbidity and mortality versus individuals with lower frailty scores regardless of age. Hearing loss is associated with increased rates of frailty, as is falls. I found it interesting for the endoscopic endonasal skull base literature. Frailty was not correlated with any other parameters other than readmissions within 30 days. But otherwise, frailty had no impact, interestingly, on their surgical outcomes. So if you haven't looked at frailty or haven't seen a frailty scale previously, it's just looking at your patient's overall functional capacity. This is one example of a frailty scale, the Rockwood Frailty Scale, which starts at number 1, a very fit individual. So someone who's probably in the top 10% of their age category. Most individuals who are well would follow into a 2. So they're active, but less active than those individuals in category 1. 3 are well managed. They exercise regularly on occasion. People in category 4 are vulnerable, so they tend to get tired multiple times and throughout the course of the day. The mildly frail individuals have evidence of slowing. They need help with activities of daily living. And by the time you get to moderate, you have even more challenges and inability to care for themselves without having the assistance of a caregiver. And then level 7, the severe frailty, they're completely dependent upon others. Very severe frailty is getting towards the end of life. And then there's a separate group of terminally ill, which is regardless of their frailty, that their life expectancy is less than 6 months. So aging and otology, just a couple of things to highlight. The American Academy of Otolaryngology Head and Neck Surgery put forth measures for age-related hearing loss a few years ago. And one of the metrics that they look at is the percentage of individuals over the age of 60 who are screened for hearing loss. So the goal of this was to advocate amongst otolaryngologists, but also primary care providers and all specialists to screen individuals over the age of 60 for hearing loss just by asking them. And if they do report that there is a positive hearing loss, then referring them for appropriate comprehensive audiometric evaluation within 4 weeks of that visit. And also engaging in shared decision-making with that patient about options for oral rehabilitation. And then an important part of this is advocating against imaging for people who have symmetric hearing loss complaints. The Academy is now working on age-related hearing loss guidelines. They've actually been in development. They're already in review. I believe the public review is either pending soon, and so they should be published within the next year. So we will have age-related hearing loss guidelines, which kind of give you a step-by-step how to manage patients with age-related hearing loss. But one thing I just want to reiterate to this group here is advocating for your patients to get oral rehabilitation. So even for me, since I've been in practice, I've been in practice going on 15 years now. Starting off my practice, if I had a patient who had a mild sensorineural hearing loss and the patient said, I don't really notice my hearing loss, it doesn't bother me, my family notices it a little bit, but I don't, I would say, okay, well, once you're ready, once you notice those changes, then it's time to consider getting a hearing aid. With the new data that's come out that's very compelling about dementia, I've been advocating for those patients with mild to moderate hearing loss to consider getting hearing aids because it decreases the risk of dementia over life and decreases the severity of those individuals who already are starting to develop dementia. And with the over-the-counter hearing aids becoming available, as well as with increasing coverage by payers, hearing aids really are available to a wider population of patients. And one thing I found, just to share with the group, that if in discussions with these patients that are resistant to obtaining hearing aids, I actually let them know about the data of dementia. And some patients who aren't as sophisticated in understanding what the word dementia means, I just tell them it helps you to stay sharp. You know how when you go into another room and you forget why you went in there, it can sometimes help with preventing that from happening and progressing. And most patients know somebody who has dementia, and it's enough to compel them to change their mind and consider at least having that consultation with an audiologist for hearing aid evaluation. And then also making sure they're aware of the broader options for hearing oral rehabilitation, particularly for individuals who are at that advanced stage of severe to profound hearing loss. Knowing that cochlear implantation is most often an option. There's no upper limit on the age for cochlear implantation. The oldest person that's ever been implanted, to my knowledge, is 99 years old. There's minimal risk in extremes of age as long as the patients have lower frailty scales and can tolerate a general anesthetic. Although in recent years, cochlear implantation has been done even by myself under conscious sedation with local anesthesia, very successfully, very easily, similar to how we did stapes procedures. It's the same concept. And it improves quality of life for patients overall. And then a little bit on presbystasis. I think this literature we're not as aware of in otolaryngology, but it's our patient population as well. 1 in 4 seniors fall every year. 1 in 5 fall and have a head injury or broken bone. And every 20 minutes, a senior dies as a result of a fall. So this is within our wheelhouse to treat and to really impact these numbers. So again, I won't belabor the point of all vestibular patients because Dr. Bojob did a great job of going through that, but just I want to say advocating for vestibular rehabilitation, can be multifactorial, as he mentioned, making sure that we're working with our primary care providers to understand the etiology of these patients' presbystasis, and making sure that they understand the impact on quality of life, but positively advocating for that vestibular rehabilitation in this patient population. And that's what I have for you.
Dr. Briggs, question real quick.
Sure.
Can you speak to your experience and thoughts on dementia and cochlear implants? How aggressive are you, and what's been your experience? Cognitive issues.
Yeah, so I've had a number of patients with cognitive issues and who are implant candidates, and I tend to advocate for those patients to consider cochlear implantation, and that's the key population that I actually do it under conscious sedation with local, because those patients are often concerned about undergoing a general anesthetic.
So a question for you. There's pretty good data that started out, from the group in Oregon at OHSU talking about putting hearing aids in people and improving their balance. Do you think it's just a stimulation of the ear that's overall? And what is your thought on that?
I think it is stimulation of the ear, but I also think that our sense of balance and our awareness of where we are in space is largely associated with those acoustic feedback that we receive from the environment. So if you can think about it yourself, if you have your AirPods in and you have the noise cancellation and you're walking around, it impacts your sense of balance as well. And so I think it's just having that acoustic feedback from the environment also that impacts our sense of balance.